Good evening, folks. I've got discussion C for you. We're discussing can palliative care consults in hospitals improve end of life care? Frames a central question in modern healthcare, whether systematically embedding palliative care into hospital practice can make dying less painful, more dignified, and better aligned with patient wishes. The surrounding page content describes a major pragmatic trial funded by the National Institute on Aging that tested this idea by shifting palliative care consults from an optional service to a default part of care for seriously ill older adults. Study design in plain terms. The trial enrolled patients age 65 and older with serious illnesses across 11 community hospitals. Two approaches were compared. Default consult orders. Palliative care consults were automatically ordered for eligible patients unless clinicians actively opted out. Usual care consults were only ordered if clinicians specifically requested them. This design tested whether changing the choice architecture, making palliative care the defaults, could normalize its use and overcome barriers like time constraints, uncertainty, or reluctance among providers. Main results. What changed? The study found clear differences in how care unfolded. Consultation rates rose sharply, nearly half. 43.9% of patients in the default group received a consult compared to only 16.6% in usual care. Consults happened sooner. Patients in the default group were seen by palliative teams more than a day earlier on average. End of life processes improved. These patients were more likely to have do not resuscitate order documented at discharge and were more often transferred to hospice, signaling better alignment with patient preferences and smoother transitions out of acute care. What did not change? Despite these processes, improvements, the trial found no differences in hospital length of stay, in hospital deaths, or other clinical outcomes between the groups. In other words, default consults improve the quality of life, quality of end of life planning, but did not alter the quantity of hospital use or survival outcomes in this study. Clinician response and practical implications. Interestingly, clinicians canceled only 9.6 of default orders, suggesting that the opt-out model was broadly acceptable and did not provoke significant resistance. The authors note that while default consults increased palliative care or palliative involvement, their impact may be limited by staffing shortages. Expanding palliative care teams are pairing default orders with additional resources could amplify benefits, potentially improving symptom management, family support, and care coordination. Broader contexts. This trial reflects a growing recognition that end-of-life care in hospitals often falls short. Patients may receive aggressive interventions that conflict with their values. Families may feel unsupported, and transitions to hospice can be delayed. By embedding palliative care earlier and more consistently, hospitals can shift toward care that prioritizes comfort, dignity, and patient choice. Bottom line takeaway: making palliative consults the default in hospitals increases and accelerates palliative involvement and improves key end-of-life care. Processes such as DNR, documentation, and hospice referral, while it did not shorten hospital stays or change mortality, it represents a promising systems level strategy to normalize palliative care and ensure that seriously ill patients receive timely, value-based support. To fully realize its potential, hospitals may need to pair default consults with expanded staffing and resources. Okay, guys, those are it for tonight. So I will see everybody tomorrow or Monday for shows. For now, Gator Wellness. Take care, folks. Have a good evening.